Welcome to the third Patna course on neurointervention. Before we start this course, this was my teacher, Professor Anton Malvanis. He was the director of the Institute of Neuroradiology at Zurich University Hospital. He started the department in 1978, and he became the first chairman of the department in 1980. And he remained the chairman till 2015. And he is the one who's responsible for the development of neuroangiography as we know it today. He was the student of Professor Yashergill. And basically, his training started off as a neurosurgeon. Then he changed over to neuroradiology. So whatever you see and whatever we have learned is basically a combination of microsurgery and neuroradiology together. And just would like to pay my respect to this man, because whatever we have learned is thanks to the developments in neurovascular angiology that has been done because of him. Now some important things that before we start. This is going to be a slightly atypical kind of meeting, because this is not a congress. This is a meeting in which we have decided to take up one particular area, for example, the spinal cord. Start with the angioanatomy and the phylogeny of the spinal cord. Then go on to how the vessels look, how they are developed, from where they come, and subsequently case examples of spinal cord disorders. By spinal cord, I mean both dural disorders of the spine as well as intrinsic cord disorders of the spine. Another request, this entire meeting will be recorded. It will be available to you as participants after the course once we do the post-production. So please, please, please keep your mobile phones on silent mode, because all these sounds will be picked up in the ambient recording, and that irritating noise which comes when someone's phone is ringing, that is something which is not good when you see the video later. It does not make a difference here, but later on it becomes a problem. So with that, basically what I thought is I'll start with the anatomy of the spinal cord. I will try and show you how exactly the vasculature of the spinal cord is derived. And instead of doing it the conventional way by using slides, I will do it on the board, so that maybe you have some scribble pads in front of you. You can also draw along with me, so it makes more sense and then you understand it better. When we start discussing the angioanatomy of the spinal cord, we first have to understand what is the construction of the spinal cord. How exactly is the spinal cord made? Now, we are all vertebrates. Humans are vertebrates. Basically, what does being a vertebrate mean? It basically means that our entire body, from bottom upwards, is made up of segments, is made up of distinct segments which are called as metameres. So if we were to look at the spinal cord, first I will just try to draw the entire neuroaxis, and I'll try to show you what are the segments in the entire neuroaxis. Then from these segments, we will pick out one segment, that is going to be the spinal cord. And then we will start trying to analyze the angioanatomy of the spinal cord. So basically, whenever you draw a cornal section of the brain, you have the telencephalon on the top. You have the posterior fossa contents, which is basically the cerebellum on both sides and the brainstem in the center. And then you have the caudal extension of the entire neuroaxis, which forms the spinal cord. So basically, if we were to look at this entire system, we find that you have 32 segments in the spinal cord. You have the pro-atlantal system at the CV junction. You have the hypoglossal system again at the CV junction and slightly beyond. And finally, you have the trigeminal system. So what is important for you to understand is 32 segments in the spinal cord, 1 to 2 segments in the proatlantal system, another one segment in the hypoglossal system, and another one segment in the trigeminal system. These are a total of 35 segments where the blood supply, the angioanatomy, is relatively straightforward. For example, if I were to take one segment, one metamere will consist of the vertebral body, the neural element within the vertebral body, that is the spinal cord, the nerve roots, which is the peripheral nervous system, the covering, which is the dura, the bone, which is again a derivative from the sclerotome of the somite, and subsequently muscles, fat, and soft tissue. So whenever we talk of a metamere, whenever we talk of these 35 metameres, we have to understand that each of these metameric vessels, each of these 35 metameres will have one vessel. Now, each of those vessels will supply the peripheral nervous system, the central nervous system, the covering, that is the dura, the bone, the muscles and soft tissue, and the supporting structures, including the skin on the top. So whenever we talk of a spinal cord disorder, we first have to understand the angioanatomy of the spinal cord. And when we are trying to understand the angioanatomy of the spinal cord, we also have to understand that any artery which supplies the metameric structure of the spinal cord will also mandatorily have a memory of its supply to the other 5 structures. So spinal cord disorders, whenever we are talking about a spinal cord AVM, it is not just important to look at what is happening inside the spinal cord. Because the metameric artery which will be supplying the spinal cord will also be supplying these structures. The converse is also true. You can have an AVM on the skin, on the back. You cannot look at it just as a skin of the, as an AVM of the skin which is on the dorsal aspect. You have to study the spinal cord because it is quite likely that the same segment, for example, you have a lesion at L1, it is quite likely that at the L1 segment metamere of the spinal cord, you will have an associated disorder. So this is the first concept that you have to understand. The second concept that you have to understand is about the blood supply. This entire neural axis is ultimately going to derive its blood supply from the aorta. In the embryo, this aorta is represented by the dorsal aorta and the ventral aorta. We'll come to that. In the spinal cord, in the 32 segments of the spinal cord, it is relatively straightforward. You have radicular arteries which come from the aorta or the aorta-like structure, and they supply their own parts of the spinal cord. So now we have to understand how exactly these metameric arteries, which were present from the aorta in the early stages of phylogeny, come to form the complex neural and vascular network as we see in the adult spinal cord. So what I'll do is, I'll go away from this diagram. We will keep this as a reference because I'm also trying to tell you that the simplest angioarchitecture will be available in this area, 32 segments. The moment you reach the proatlantal and the CV junction, it becomes slightly more complex. Go to the hypoglossal, it becomes more complex. Reach the trigeminal, and this is where the real complexity starts. I have not said anything above the trigeminal artery, because there it is not just a metameric concept, it is something else, which we will discuss in a separate meeting. But as of now, we are going to explain what exactly happens at this level. You also have to understand that in this axial section, the aorta is placed somewhere here. The aorta is placed in the anterolateral part of the vertebral body. Now, you have radicular arteries which go to both sides. One radicular artery crosses over the vertebral body and reaches the intervertebral foramina on the opposite side. The ipsilateral side goes directly. The most important concept that you have to understand in the spinal cord is that the blood supply from the aorta to the spinal cord always reaches via the spinal nerves. Because these vessels, they have to have a pathway which they can track and by which they can reach the spinal cord. So the first concept that you need to understand is that in the entire central nervous system, the peripheral nervous system is the one which carries the blood supply to the central part. Since we are talking only about the spinal cord, we will restrict our discussion to the spinal cord, and we will say that any artery which has to supply the spinal cord has to go along the nerve roots. This is the first principle that you have to remember. So whenever you are doing an angiographic exploration and you find an artery which is not following the expected trajectory of a nerve root, you can be sure that this artery is not going to supply the spinal cord. That is the first point. I'll just illustrate this with an example. For example, you have an AP view where you are looking at an AP angiogram of the spinal cord, of a radicular artery. Let's say this is the field of view that you are seeing, and you are somewhere in the mid-dorsal region. You are, let's say, at around D6 or D8. At D6 or D8, you expect a certain obliquity to be present in the radicular artery, which should go to the spinal cord. For the simple reason that at the cervical region, the nerve roots are almost horizontal. At the mid-dorsal region, they are slightly oblique. At the lower dorsal region, they are more oblique. And as you come towards the cauda, the conus medullaris, the nerve roots become almost vertical. So in an AP view, now when you are engaging, for example, this artery with your catheter, that's your catheter by which you have engaged this artery. And what you are seeing here is, you are seeing an artery which is going obliquely like this, and that artery is giving some tiny small branches to the spinal cord. But you also have a big malformation somewhere here, but this malformation is being supplied by an artery which is coming from the same pedicle but has a more horizontal or horizontal-like course. Looking at the AP view itself, you can be sure that this artery, which is supplying the vascular malformation, is not an artery which is supplying the cord. So in the AP view, immediately you can realize that this is something which is extradural. It is maybe on the spinous process, it is maybe in the muscle, it is maybe in the back, but it is definitely not in the spinal cord. So the first principle, the peripheral nervous system will carry the blood supply to the central nervous system, that is to the spinal cord. The second principle, the artery that is carrying the blood supply to the spinal cord has to be mandatorily follow the root of the spinal nerve. Therefore, you can use the trajectory and the obliquity of the spinal nerve as an idea so as to where your artery is going to be. So this is the second point. So these are basic points about spinal vascularization. Now let us get into the spinal cord and see in embryology how the spinal cord develops, and then subsequently how this vasculature comes to be in this phase as we are discussing. We'll move to the other board. We'll preserve that image. So what we do is, we draw a spinal cord. We draw a vertebrae first. Now the spinal cord is going to be contained inside this vertebral body. So what we will do is, we will open this vertebral body like this, so that once we open it like a book, you will have the spinal cord in the center, and then you will have the two halves, the right half and the left half, on either side in the diagram. Then we will be able to explain how exactly the entire vasculature develops. So when we open this up, let's say that's one vertebral body, second vertebral body, third vertebral body, fourth vertebral body. That's on one side. Then you have the same thing on the other side. In between these two, you basically have the spinal cord. Based on the first principle that we discussed, we said that the peripheral nervous system is going to be the carrier of the metameric artery to the spinal cord. So in the first phase, what will happen is, the radicular arteries and the aorta, which are on the side, will give one branch to each of the metameres, and these will be connected to the aorta on the exterior. You are here with me till now? No doubts? Okay. So now we have a situation in which the primitive spinal cord is developing in the center. This primitive spinal cord is extracting its blood supply from the aorta on both sides, aorta via the intercostal arteries. Now this intercostal artery is traveling in the intervertebral foramen. Now as this artery is traveling in the intervertebral foramen, it will also give blood supply to contiguous halves of the vertebral body and the intervertebral disc. So basically, if we stop for a moment now, we realize that the somatic supply of this artery is going to be to the lower half of the upper vertebrae and the upper half of the lower vertebrae and the disc in between. So this is the territory of a metameric supply, a metameric somatic supply from the primitive arteries. Now these arteries, while supplying their somatic structures, will proceed and they will give an ascending branch and a descending branch. They will give an ascending branch and a descending branch. Ascending branch and a descending branch. Ascending and descending. Now this is on the surface of the developing spinal cord. The same thing will happen on both sides. The same thing will happen on both sides, so that now you have a situation in which each metameric artery is supplying its somatic component. After supplying its somatic component, it is extending into the spinal cord cavity. On the surface of the spinal cord, it is giving an ascending branch and a descending branch. Again, ascending, descending, ascending, descending, and so on and so forth. In the next step, what is going to happen is, we'll draw that here itself. These arteries come very close to each other. These arteries come very close to each other, the ascending and the descending branches, and they anastomose. So in the next phase, you have a metameric artery, ascending, descending. A metameric artery, ascending, descending. A metameric artery, ascending, descending. A metameric artery, ascending and descending. You have the same thing on the opposite side. So at this level, we can already see that a structure to the blood supply of the spinal cord is emerging. You can already start seeing how the adult vasculature is going to look. In the next step, these arteries become nice and straight, and these arteries are the ones which are referred to as the longitudinal neural arteries. So the longitudinal neural arteries that develop on the surface of the spinal cord are basically formed by a process of the fusion of the ascending and descending segments which come from the metameric arteries. Now, in the next phase, these metameric arteries, which have formed the longitudinal neural artery, move closer to each other, and these two longitudinal neural arteries fuse. Before they fuse, if I again draw the spinal cord right here, you also have to realize that the vasculature has developed for each half of the cord. That means this longitudinal artery will give blood supply to this half of the cord, and the other longitudinal neural artery will give blood supply to its own half of the cord. This is a very important concept that you have to remember when we go to the next stage. Remember that the blood supply of the spinal cord has been designed to be a blood supply of one half of the cord. Over the next few days of embryological development, we find that these arteries, the two longitudinal neural arteries, which were very close to each other, they fuse. So now, from a metameric supply in which each metamere was being supplied by its own artery, you had the formation of a longitudinal neural system. The longitudinal neural system was again giving supply to its own half of the spinal cord, and subsequently the longitudinal neural system also on both sides fused to form one single vessel, which will be called in the future as the anterior spinal artery. So in the spinal cord, the most important thing to remember is that the anterior spinal artery is basically a product of the fusion of two longitudinal neural arteries starting from below and going upwards. Now the same process of fusion of two systems occurring and going up will happen throughout the neuroaxis. For example, at the spinal cord level, it is the longitudinal neural artery. At the CV junction, before that, I would like to show you something else here. Now, anterior spinal artery, radicular artery which is going and forming, giving contribution to the longitudinal neural artery. When these fuse, sometimes the fusion is complete, like what I showed here. This happens when there is only one dominant stream coming from one side. Supposing the stream from the other side was not as dominant, that artery will regress, because that artery will have nothing to supply to, because the supply has been taken over by this place. But supposing you have two equally dominant arteries from both the sides, which are coming and supplying the spinal cord, what's going to happen is both these arteries will remain, and at the center where the fusion remains incomplete, you will start seeing this diamond shape. So this diamond shape basically is not a fenestration. It is called a fenestration, but it is not a fenestration. It is a lack of fusion. When there is a lack of fusion, you will have a situation in which you get this diamond shape. Now start imagining where else you see this diamond shape. Now we'll come back to that diagram. At the CV junction, now we have reached a stage when we have two longitudinal neural arteries which have fused at most of the levels. They have also remained unfused at some levels. And basically, at the CV junction, you can see that again it remains unfused. That is the vertebral artery, that is the vertebral artery, that is the basilar artery. So basically, even the lower part of the basilar artery is a product of the fusion of the longitudinal neural arteries. The territory of the longitudinal neural arteries on the basilar artery is up to the origin of the ICA. So up to the ICA, the basilar artery is formed by a fusion process from below. Above the ICA, it is again formed by a fusion process of the caudal divisions of the ICA. We'll go to that later. So again, at the VB junction, you see the diamond. Then you go up, you go into the VB junction, you go into the basilar artery, you go into the posterior part. Again, you have division into the so-called division or fusion of the caudal processes of the vertebral artery. Then you have the circle of Willis. Again, not a diamond, but a hexagon. So again, the circle of Willis is a product of the non-fusion of the three competing streams from three sides. You again go up, anterior cerebral arteries, anterior communicating artery. Again, the process of fusion, the extreme of which is the so-called azygous ICA. So this fusion process starts from below, gets completed at the spinal cord level, goes into the posterior fossa, goes into the VB junction, then subsequently goes into the circle of Willis, the basal circle of Willis, again incomplete fusion, and then subsequently you reach the supratentorial system into the anterior cerebral artery territory, which again starts fusing, but the fusion is incomplete, and in an incomplete fusion, again you see the classical disposition, but if you have a complete fusion, you will see an azygous ACA. So what I'm trying to say is, this basic plan that we are discussing at the level of the spinal cord is going to help us in the spinal cord, it is going to help us in the CV junction, it is going to help us in the posterior fossa, in the brainstem, in the circle of Willis, and subsequently into the supratentorial space. So now we have established in that diagram how exactly the blood reaches the spinal cord. So once the blood reaches the spinal cord, it has to be distributed. So now we start going into the details of this particular system, and we will draw some more diagrams here. We will preserve that. We will erase this. So now we will draw the spinal cord again, but this time we will draw a slightly oblique section of the spinal cord, an oblique longitudinal view of the spinal cord, so that you can see the anterior and the posterior roots as well. This board is a bit small, so we'll have to draw a smaller one. That is the central canal of the spinal cord. That is the posterior, lateral, and the anterior horn of the spinal cord. Now we also need to draw some roots. These are the anterior roots from the anterior funiculus, and then you have some of these posterior roots from the posterior funiculus, ultimately forming the peripheral root. So what we have discussed as of now is that the blood supply to the spinal cord will follow the nerve root. So basically, what is going to happen is, you're going to have an artery which is going to come via the nerve root. Obviously, the anterior spinal artery is an anteriorly placed structure. So this artery has to mandatorily follow the anterior root, the ventral root. This reaches the midline, crosses over the anterior funiculus, and then forms the anterior spinal artery. So any artery which follows the ventral nerve root crosses over the anterior funiculus and gives you this characteristic loop, this characteristic bend, and then continues as the anterior spinal artery, is basically called as a radiculomedullary artery, because this artery is a branch of the radicular artery and it is contributing to the supply of the anterior spinal artery. Therefore, this is a radiculomedullary artery. You will have some arteries which follow the anterior root. They cross over the anterior funiculus, but they don't reach the midline. These small arteries, they give a series of small branches to the surface of the spinal cord, and therefore these arteries are referred to as the radiculopial arteries. Pial arteries, pile arteries, whatever you want to call it. This artery, even though it is coming via the anterior nerve root, is not going to supply the medulla. Whereas the anterior spinal artery is going to give branches to the gray matter, to the entire gray matter up to the posterior horn. So whenever you are dealing with a vascular malformation in this territory, in the territory of the radiculopial artery, obviously the risks are not the same as they are when you are dealing with a radiculomedullary artery. Now this is the story of the anterior root. What happens to the posterior root? You have branches from the posterior root again going to the posterior surface of the cord and then supplying the same sleeve around the cord, the PL surface around the cord, and these are referred to as the posterior radiculopial arteries. So till now, the most important branches as far as the spinal cord is concerned is going to be the branch which is starting from the ventral root, going along the ventral root, going over the funiculus, and forming the anterior spinal artery. As far as these roots are concerned, now we will draw some more on the opposite side. Now, as far as these arteries are concerned, generally, you have one large one at the cervical level, and you have another large one at the lumbar level. So this is your artery of the cervical enlargement. This is your artery of Adam-Kivix. Now, once we know how these vessels reach on the surface of the spinal cord, let us take a cross section at this level and try and understand how these vessels will supply the interior of the cord. So for that, we again come to this place. Now we will draw an axial cut. Now we draw an axial cut of the spinal cord. We draw the central canal somewhere here. We draw the funiculi. Now, the anterior spinal artery, which was this artery, this has already come to the midline, and this lies in the anterior median fissure of the spinal cord. So this artery lies somewhere here. Whereas all the other arteries, the anterior radiculopial, the posterior radiculopial, these arteries are on the external surface of the cord like a sleeve. All these tiny arteries on the sleeve, they are anastomosed to each other to form what is called as the pial ring or the arteria vasocorona. As far as the cross-sectional supply is concerned, we already discussed that the anterior spinal artery is basically a product of the fusion of the two longitudinal neural arteries. This essentially means that you can divide imaginarily the anterior spinal artery into two halves, and each half will have a perforator which will supply its own half of the spinal cord. So as far as the branches from the anterior spinal artery are concerned, these are the branches that are formed in the depths of the anterior sulcus. These are the so-called sulcocommissural arteries, and each sulcocommissural artery will supply only its half of the cord. Now this sulcocommissural artery will supply the entire gray matter up to the posterior nerve cells, up to the posterior root. This entire structure will be supplied by the sulcocommissural artery from the anterior spinal artery. If you look at it in longitudinal section or in a sagittal section, you will find that this is the anterior spinal artery, and in the depths it will give supply via sulcocommissurals to its own half of the cord. So what I'm trying to say is, if you have a disorder, if you have a malformation that is supplied by the anterior spinal artery, you have the radiculomedullary. From the radiculomedullary, you have reached the anterior spinal artery, and from this sulcocommissural, you have a vascular malformation on this side. If you can get your microcatheter in this radiculomedullary artery, From this radiculomedullary artery, you reach the anterior spinal artery. And from the anterior spinal artery, you enter into a sulcocommissural artery. And from this area, if you inject your embolic substance, like glue, into this vascular malformation, and you have no reflux, absolutely. The only risk, the only prospective risk, is going to be to one half of the cord. So you can never produce a complete section of the cord if you are deep into the sulcocommissural system. If you are really deep into the sulcocommissural system and you have the flow going only into the vascular malformation, the chances are almost zero. So whenever you are dealing with the anterior spinal sulcocommissural system, the idea is to spend time on catheterization and get as deep as possible. As far as the arteria vasocorona is concerned, they basically give a series of tiny branches only to the white matter, only to the funiculi. So whenever you are dealing with a vascular malformation, or whenever you are working in the posterior part of the spinal cord or in the arteria vasocorona, which is not opacifying the anterior spinal system, the risks, if you have again no reflux, are next to none. Because this is a very, very rich anastomosis on the surface of the spinal cord. What you also need to remember is that the anterior system, that is the system from the anterior part of the spinal cord, I mean the anterior spinal artery, which goes up to the posterior horn, this anastomosis with these twigs from the posterior spinal artery, from the arteria vasocorona. So there used to be a dictum which used to say that if you have a vascular malformation supplied by the anterior spinal artery, it has to be intramedullary, because the territory of supply of the anterior spinal artery is the entire cord. So in the pre-MR or in the pre-imaging era, if you find a lesion which is, for example, sitting here, this is a lesion which is sitting on the dorsum of the spinal cord, or maybe in the subpial zone of the spinal cord. But this is being opacified via this anastomosis, which is coming from the anterior spinal artery, going through the cord, and then anastomoting with the arteria vasocorona. It was thought that this has to be intramedullary. That is not the case. We have a lot of extramedullary intradural lesions on the posterior surface of the spinal cord, especially the high flow fistulas, which are supplied in this fashion. The problem is they have a sump effect that is so strong that they sump the blood from the opposite radiculopial, the ipsilateral radiculopial, as well as from the anterior spinal system. So in this situation, the anatomy and the location of the lesion on a cross-sectional image is the one which tells us where exactly this lesion is. Another important point, what we have to understand is, the anterior fissure of the spinal cord is bridged by pia mater. So the anterior spinal artery in its entirety, the entire course of the anterior spinal artery, is subpial, whereas the arteria vasocorona is subarachnoid. So if you have a lesion which has bled and you have extensive subarachnoid hemorrhage, your lesion is more likely to be fed by the arteria vasocorona. But if you have a localized anteriorly placed hematoma in the spinal cord, the chances are that the problem is in the anterior spinal artery. What you also have to remember is that What you also have to remember is that the anterospinal vein is located in the depths of the anterior median fissure. So there are a special group of spinal cord vascular disorders which are due to fistula formation between these two vessels themselves. Very difficult to diagnose because the distance between these two is hardly any. The moment you inject this radicular artery, you will see the radicular artery and then the venous system being opacified. So please remember, the location of the vein is quite deep. The location of the artery is quite superficial. So this superficially placed artery is capable of forming a microfistula within the substance of the spinal cord, which is again not intramedullary. It is actually extramedullary, but intradural. So again, this is very, very amenable to endovascular treatment. So this is as far as the blood supply of the spinal cord is concerned. I have left out the blood supply at the CV junction. I will just tell you a couple of points about that. We have discussed that the radicular artery brings the supply to the spinal cord. Now, as you reach the CV junction, the proatlantal arteries will start playing the role of radicular arteries, but proatlantal arteries are not present in every angiogram. So in every angiogram, which is that vessel which behaves as a homologue of a radiculomedullary? It is basically the vertebral artery. So vertebral artery, as far as the entire discussion of vascular angiology is concerned, is a homologue of the radiculomedullary artery, as well as it is a combination of multiple intersegmental arteries. I'll tell you what exactly that means. But suffice to say, the uppermost part of the spinal cord is going to try and derive its blood supply from the vertebral artery or some branch of the vertebral artery. Vertebral artery, the first constant branch that comes in that region is the pica on both sides. So the candidates that are available to the spinal cord are either the pica on both the sides or the distalmost part, the extradural part of the vertebral arteries themselves. So you have a series of tiny vessels which start developing at this area, and then one of them gets selected to connect with the arteria vasocorona on the posterior aspect of the spinal cord. This vessel can be a branch from the vertebral artery, or this vessel can be a branch from the pica. Now this vessel is called as the lateral spinal artery because at the CV junction or lower in the posterior fossa, it is not posterior, it is lateral, it is on both sides. And as it comes down, it converges on the posterior aspect of the spinal cord and forms what is called as the posterior spinal artery. So whenever you have a vascular malformation in the lower part of the spinal cord, I'm talking about an intramedullary vascular malformation. I'm not talking about dural malformations. Your access will be from the artery of Adamkiewicz. Whenever you are working in the upper cervical cord, your access will be from the artery of the cervical enlargement. And whenever you are working at the CV junction, your access will be either from the proatlantal, if it is present, or from the occipital artery, if it's quite large, or from the vertebral artery directly, or from the pica. Now please remember that any vessel which goes from the vertebral artery into the posterior surface of the cord is again a radiculo-PL contributor. It is not a radiculomedullary. So the chances of having problems while working in that axis are much less. Whenever you are looking at the pica, the pica also contributes to the arteria vasocorona, again on the posterior surface of the cord. So again, the risks will not be similar to those that you see from the radiculomedullary arteries. This is as far as the vasculature on the surface of the brainstem and the intrinsic vascularization is concerned. One more important thing you need to know is, this is the spinal vascular system. Now, the spinal vascular system is the oldest vascular system in the entire central nervous system. So it has developed a series of anastomotic pathways which give it a lot of redundancy. So once you have understood the intrinsic spinal vascularization, now is the time to also try and understand how exactly the collateral circulation works in these areas. So again, we will draw a very simplified version of the cord. What we have seen is, you have the anterior spinal artery, you have the posterior spinal artery or the lateral spinal artery, as you want to call it. The posterior spinal artery forms anastomotic channels and even some contribution from some anterior radiculopial arteries, so that the entire cord is covered like a sleeve. And then you reach the bottom part of the spinal cord. Now this is the conus medullaris. Beyond the conus medullaris, there is no tissue for the anterior spinal artery to supply. Because below the conus medullaris, you just have the filum terminale and you have the cauda equina nerve roots. So the cauda equina nerve roots, again as we have discussed, will be supplied by the radicular branches. These radicular arteries will supply their own peripheral nervous system. But since below this point there is no more central nervous system, these arteries will stop by supplying the nerve root. The anterior spinal artery will also reach the end of the conus medullaris, and the posterior spinal arteries also will reach this end from behind. At the lowermost part of the spinal cord, these will anastomose. So you will have the situation in which, if you are injecting the adamkivics, you will see that the anterior spinal artery comes down, it stops at a point, from there it goes back and starts supplying the posterior spinal artery. So this area is called as the basket of the spinal cord. So whenever you identify a basket on spinal angiography, it tells you there is no more central nervous system below that. So obviously, your tendencies for embolization, catheterization, all will be different, and you will have much more leeway in that area. Now, this is the intrinsic spinal cord vascular system. The brain has also developed a lot of anastomotic channels, which are the so-called extraspinal paravertebral vascular systems. Extraspinal paravertebral systems are basically combinations or anastomoses of multiple radicular arteries joining together and forming one common channel, so that if you have a problem with one, the other two will still continue to supply. At the level of the CV junction, it is basically the vertebral artery, which is a combination of multiple intersegmental arteries. You can have branches coming to the cord or to the anterior spinal axis or to the pia from different levels of the vertebral artery, again for redundancy. At the thoracic level, you basically have an anastomosis in the form of the supreme intercostal artery, in which the upper 3 or 4 intercostal arteries are anastomosed into a single channel, and from here, blood supply comes and goes into the spinal cord. And at the bottom, you basically have an anastomosis in the form of the lateral sacral artery. So please remember that the vertebral artery, the supreme intercostal artery, and the lateral sacral artery, they are basically extraspinal, paraspinal, artery to artery anastomotic channels. So whenever you are doing a study of the spinal vasculature, your study will not be complete till you have selectively engaged and catheterized these 3 as well. Because you might not find an Adamkiewicz, but when you do an injection of lateral sacral artery, you find that it is giving you a radiculomedullary. So if you find something above, fine. But if you are not finding something above, you have to make sure that you study this, this, and this. So these 3 are a must. So I feel, as far as the spinal cord is concerned, the spinal cord below the CV junction, this much of discussion should be enough for us to be able to discuss the images that we are going to discuss in the next half of the program. So if there are any doubts at this level, any doubts, please stop and ask, because immediately we will go into the applications. We will start showing you angiograms, and then what we will do is the angiogram will be showed on the board, and then we will come here, we will draw it, and then we'll try to thrash out the entire pathway. You can immediately understand that as far as the vascularization of the dura is concerned, the dura can be supplied by any of these vessels. The artery which is going to become a radiculomedullary can also give a radiculomeningeal branch, which is going to supply the dural fistula somewhere here. The artery which was becoming an anterior radiculopial can also give a supply to the dura on the way. The artery which was a posterior radiculopial can also give supply to the dura on its way. So the principles will remain the same. Whenever you are catheterizing an artery in a dural fistula or in an intramedullary disease, you have to behave as if it is a radiculomedullary. You have to make all attempts to show that this is a radiculomedullary. For example, you have catheterized a cervical artery or maybe a branch from the vertebral artery, which is supplying a dural fistula. You have catheterized it, you have engaged it, and you are seeing that it is supplying only the meninges. As long as it is posterior, there's no problem. But it can be anterior. So if it is anterior, how do you know that this branch again is not going to go and continue and reform the anterior spinal axis? For that, you have to find the radiculomedullary of that area and demonstrate from where the radiculomedullary system is opacifying of that area before you embolize this. Remember again, posterior, no problem. You can go ahead and embolize. But if it is anterior, you have to feel, behave, think as if it is a radiculomedullary. Because you never know. These are principles. We say that the anterior radiculopial cannot anastomose with the anterior spinal artery. But one fine day you will find a case where it did anastomose. So in that you'll have a disaster. So anterior, be careful. Posterior, be careful, but relatively safe. Once we are through with this, the final part in the spinal cord that is left is the supply of the filum terminale. That is again an important structure. We'll draw the filum terminale in between somewhere here. That is the caudal end of the cord. That is the filum terminale. That is your sacrum, and this is where your filum is attached. So we have already discussed that at the conus medullaris, the anterior spinal artery ends and the posterior spinal artery comes in anastomosis to form the so-called basket of the spinal cord. The filum terminale, embryologically, is a derivative of the spinal cord. So obviously, the supply to the filum terminale has to come from the medullary artery of the spinal cord. Therefore, the only artery which is going to supply the filum terminale is going to be the anterior spinal artery. Below the basket, you have the nerve roots of the cauda equina. Any radicular artery, this cauda equina will have radicular arteries. You will have, they should have come a bit more vertically down. They should have come somewhere here and coming out like this. So the cauda equina nerve roots, which are coming out via the sacral foramina, the S1, the S2, the S3, and the S4 roots, these have their own radicular arteries from the lateral sacral. These arteries have to supply only the nerve root. These arteries supply the nerve root, and sometimes, very rarely, they also contribute to the anterior spinal axis. Very rarely. Like there are a couple of reported cases. The important point is, the sacral nerve root supply cannot supply the filum. For the simple reason that for it to supply the filum, it has to form the anterior spinal, then come down and supply the filum. Since it does not need to contribute to the anterior spinal, because the anterior spinal already had its supply from above, these arteries most often stop at the cauda equina level. So what I'm trying to say is, if you have a vascular malformation somewhere in this area, the blood supply has two possibilities. The first possibility is that it is being supplied by a continuation of the anterior spinal artery beyond the basket. In that case, this is a lesion of the filum terminale. The second situation is in which it is being supplied by a branch from the lateral sacral, which is giving you the obliquity, the expected obliquity of the nerve root at that level, that is almost vertical, and then it is supplying the vascular malformation, but it is not supplying a midline structure. This diagram, it's very easy, but your spinal cord is just as thick as this. So in the angiogram, actually, they are very close to each other. So what you have to understand is that you have hooked the lateral sacral, and the ascending segment of the artery which is supplying the vascular malformation is going via the expected obliquity of the nerve root. It is not a filum lesion, it is a cauda equina AVM. So this is an important concept when you are dealing with disorders at this lower part of the spinal cord. So I think with this, the lower part, the infra CV junction spinal cord blood supply is complete. And if there are any questions, I will take. If any part you did not understand, please ask, because the aim is to thrash it out and finish it off right here, because later we won't have an opportunity. So any questions? Yeah, Amit. Take the mic, just behind you. Sit and say.
The lower part was, means that lateral sacral part was okay, and that intercostal and cervical. What about the thoracic part? You said that if you don't find the medullary feeder from the radicular branches,
you have to construct the anterior spinal artery from whichever level it is supplying at that area. You have to find it. Because sometimes what is going to happen is, you have, let's say we are talking about T3 to T8. We are talking about this area. You have, let us say, a vascular malformation somewhere in this area. You are finding a nice radiculopial which is going along the nerve root, but it is not reaching the midline, and it is arborizing and supplying this lesion. And this is following the ventral nerve root. So it is on the ventral surface of the cord. Now, it is quite likely that this artery might be a radiculomedullary. The distal part anatomically is there, but because of the sump effect of the AVM, it is not getting opacified. So this is where even your provocative tests will fail. In fact, doing a provocative test in an AVM is superfluous, because the AVM sump effect will pull almost everything into the AVM and bypass it. So even if you get a negative provocative test, it does not mean anything. So what you have to do, you have to inject the levels immediately in the vicinity, and you have to demonstrate that, for example, the radiculomedullary is coming from the level just above it. You generally do not have two radiculomedullary arteries in consecutive levels. You will have 2 or 3 in the entire spine. So if you have been able to demonstrate the anterior axis, and you have been able to show that despite this lesion being anteriorly, there is no feeding coming from the anterior spinal axis, then you know that this is safe. You cannot assume that this is safe. You have to prove that it is safe. Okay, any more questions? Yeah.
Within the substance of the cord, the sulcocommissural arteries, as you have said that one half will supply one half.
Yes.
But in the midline, do we find any sort of anastomosis between the right and the left?
Yeah. So the anterior spinal artery is here, and throughout its length, one to this side, 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 and so forth. It is an embryological impossibility that you will have a single sulcocommissural which will supply both sides. So this is the cord now. This is the cord, and this is the artery that is, like, for example, this artery is going to supply its own half. Yeah. But you have the arteria vasocorna on the surface. So it is possible, but it has not been reported that you have anterior spinal sulcocommissural branches in the gray matter supplying a lesion of the opposite side. That is not reported. Same side it happens. There is a watershed. They don't have anastomosis across the midline. The anastomosis across the midline is in the funiculi, in the white matter, but not in the gray matter. The gray matter remains to its own side. The supply to the gray matter embryologically is distinct because of two arteries. That's why it remains on its own side. Sir.
At L4 level, mostly you find lateral sacral and medial sacral arteries. So you need to selectively go to the medial sacral artery, lateral sacral artery separately, or it is sufficient to have the...
Yeah. In fact, one point I did not discuss about the median sacral artery. So, the two internal iliac arteries and the median sacral artery, or the median sacral artery can come from somewhere here. The median sacral artery, the only way it is connected to the spinal cord is, we'll have to draw a new one. That is the median sacral artery. Now, the only supply to any structure of the spinal cord, this can supply a dural fistula, that is not a problem. This can have a somatic supply, that is not a problem. But as far as the cord supply is concerned, the only possibility here is at the S2, S3 level, where it can give a branch which goes through the bone and supplies the filum terminale. So by virtue of supplying the filum terminale, it can send an ascending segment into the anterior spinal artery. So how do you identify this vessel? This will not have the obliquity that is expected in the other vessels which are supplying the cauda equina. On the AP view, this will be a horizontal vessel which will go through the bone, and it will supply maybe the lowest part of the filum terminale where the attachment is. So median sacral artery, that is the only utility. Not necessary. Median sacral is not necessary. Lateral sacral is a must. If you have not found your pathology, and even when you find your pathology, for example, Adam Kivick's at D12, so at least 2 to 3 segments below, 2 to 3 segments above should be selected to see what is happening to the vascular dynamics in that area. Yeah. Supreme intercostal basically, do we have any diagram? We'll draw one here, okay. Supreme intercostal, basically now these are the intercostal arteries, T1, T2, T3, T4 and so forth. So basically the supreme intercostal is just an extra spinal anastomosis of 2 or 3 of the largest upper intercostal arteries. It is basically just an intersegmental anastomosis. That is why it is not constant. It is not seen in every patient. If you have independent arteries at the thoracic level, T1, T2, T3, you will not have a supreme intercostal. But if these are absent, let's say, then the T4 artery, which you can engage directly from the aorta, will form this, and then this vessel probably will go to the spinal cord.
Rahul, yeah, wonderful presentation. I have 2 questions. One is, the anterior spinal artery do have supply to this surface PL network.
Yes.
Correct? They do retrogradely give a supply to
Yes. In fact, that is one I missed. You do have some small vessels which can come and which can supply. Yes, absolutely. In fact, we have drawn that here, but we did not explain that.
Yeah, and then another one I want you to explain to the audience is the watershed in spinal cord. The longitudinal watershed and the horizontal watershed.
Longitudinal watershed is very simple, basically. because you have a lot of supply in the cervical area, you have a lot of dominant supply in the lumbar area, in the lumbosacral area, but the lower thoracic area is the longitudinal watershed. That is the area where you don't have many arteries coming in. You have an Adamkiewicz, which is for the lower lumbar segments, but let's say from T6 to T12, I'm not talking about T6 to T12 vertebral segments, I'm talking about T6 to T12 spinal segments. You do not have much supply, so that is a longitudinal watershed. In fact, that is what has been postulated to be one of the mechanisms of the high incidence of dural fistulas in that region because of ischemia. Ischemia-induced angiogenesis and then a fistula formation. As far as the internal watershed is concerned, yeah, that is very interesting. Again, we draw our axial section. We have discussed that the anterior spinal artery will give sulcocommissural branches to both sides independently, and this will supply the entire gray matter of the cord. Then we have discussed that we will have an arteria vasocorona which will give tiny penetrating branches from the anterior spinal retrograde, from the posterior spinal antegrade. And these two streams of flow, in fact, this is an area which is at the intersection point of these flows. The flow from the arteria vasocorona and the flow from the sulcocommissural. So these have been called as the internal watershed zones. These are in the funiculi. These are not in the gray matter of the cord. These are immediately outside the gray matter, in the white matter of the cord. But clinically, I don't know what is the relevance, because I try to hunt for it. In most of our genesis, it has not been a reason. In fact, that longitudinal watershed has to be a reason.
The longitudinal watershed is extremely important because most of the ischemic insult to the cord happens at that region, especially having a brief episode of hypotension, then a spinal cord dysfunction happens at that level. The internal watershed, knowing the anatomy, is more important or more relevant surgically. Like when you decide your approach, we go either dorsally, midline, and then we can go up to the spinal canal.
The funiculi like that.
We can just open the entire spinal cord like a book and operate within the spinal cord safely without causing any vascular disturbance to the cord. And the other approach we use is the root entry zone, dorsal root entry zone. Because as you said, I mean, there is a good network dorsally and they supply longitudinally the white matter fibers without causing any disturbance to them. The root entry zone is also another approach.
Excellent point, thank you. Yeah, Riddhi, microphone please. Again, if you have a prominent costocervical trunk, you will not have a supreme intercostal. So vertebral arteries, costocervical, thyrocervical, ascending cervical, supreme intercostal, all these are just longitudinal collectors. So if one is there, the second one won't be there. See, these are names. Just call them longitudinal, segmental, intersegmental anastomosis. So you can call it whatever you want. No, sulcocommissural, at one segment, you will have one to this half of the cord, one to this half of the cord. In fact, there are some articles which say that if that is a spinal cord, one sulcocommissural, then the next to opposite side, one segment below. One here, one there. So here there is a bit of a controversy, whether at the same level you have supply to both the sides or whether it is one level below the other. In fact, angiographically, we don't see the sulcocommissurals. I will show you some images of cone beam CT, which we have been doing, where we have been able to identify. But what we have seen is, in one segment, we see 2 or 3. But one sulcocommissural will definitely not supply 2 sides. In one segment, you can have 2, 3, 4 sulcocommissurals, but they will supply their own half of the cord. Anyone else? Any more questions? Spinal cord? Because spinal cord, this will not be taught anywhere else. So please, if you have any questions, let me know. No questions? Yeah.
So as you have explained in detail regarding the formation of the anterior spinal artery, how about these posterior spinal arteries? These are the dominant parts of the arteria vasa corona or what?
No, that's what I discussed somewhere there. Basically, at the top of the spinal cord, in fact, this was for the next year, but we will just touch a bit of it. See, one important thing we have to realize is vasculogenesis is a continuous process. So basically, it is not that an artery starts from above and comes down. Arteries are formed at every level. In fact, if you have the spinal cord, the arteries are being formed on the anterior surface, as well as on the posterior surface, like a sleeve. During embryogenesis, the entire developing neural tube, the neural tube is an ectodermal derivative. It is neuroectoderm. It is surrounded by tissue from the cardiac jelly, which is a mesodermal derivative. So the entire spinal cord is covered in a jelly-like substance, which is the matrix for the formation of vessels. So a meshwork like vessels keeps on developing on the surface of the cord. Now the question is, from where this is going to get inflow, from where it's going to get supply. So in embryogenesis, the rule is you get the supply from the largest vessel, which is right immediately next to you. We are sitting in this room, we want power. So we will get the power from the next hall. We will not get it from somewhere else, because this is the closest logical pathway. So as far as the CV junction is concerned, when the CV junction is developing, even the basi-occiput is a metameric structure. So the basi-occiput is developing its blood supply from arteries in the vicinity, that is the occipital and the vertebral. At the same time, the cerebellum is also developing. So all this development is happening at the same time. Cerebellum gets multiple. Cerebellum is developing somewhere here, just above. So the cerebellum starts getting its blood supply from the vertebral artery, and after some time, you have condensation of these small vessels into fixed channels, out of which one is the pica. So in the region of the CV junction, the big arteries that are present posteriorly for this developing spinal cord to take supply are the vertebral arteries and the pica. So this arteria vasocorona gets an anastomosis from either one of these, either from the pica or from the vertebral, one side from pica, one from vertebral, both from pica, both from vertebral, whatever combination. And then this slowly comes and channelizes the blood flow on the posterior surface of the cord. So basically, the posterior spinal artery is again not an artery. It is just a selection of a flow pattern which is dominant in that area, and that subsequently supplies the arteria vasocorona. So at the CV junction, this vessel is called the lateral spinal artery. And as you come below, this is the so-called posterior spinal artery. Since it is a selection of the vessels which were already there on the surface of the spinal cord, it is never a straight vessel like the anterior spinal artery. It will be slightly wavy. It will be just a dominant flow. So this is how your upper cervical cord is supplied. Okay, anyone else? Any other questions? No other questions? Yeah, Devashish.
So this you described for the upper cervical cord, but even in the thoracic cord, you often find those hairpin arteries supplied by one of the radicular arteries which are not exactly in the midline, slightly off midline.
If they are posterior,
yeah, posterior.
They are the posterior radiculopial arteries.
They are going to form the channel kind of.
Yeah, so that's a posterior spinal artery. So the most important thing is to, in angiogram, go to lateral view and see where it is. If it is posterior, it is posterior radiculopial. Adamkiewicz. See, Adamkiewicz is just a name given to the radiculomedullary of that area. So it has to mandatorily reform the entire anterior spinal axis. So no anterior spinal axis, no Adamkiewicz. Anything else? Fine. So let's see a case. Spinal cord AVM. So anyone wants to interpret this? AP view is on the bottom. Give me a pointer, please. That is the equivalent of an AP view. That is the equivalent of a lateral view. And that is an axial view. Elderly male, 57 years old. Again, the lumbar spine, that will be maybe around L1, that will be L4, L5. And then you see all these structures. So anyone? This is not the spinal cord per se. No, this is the dura, so we will not do this. Show that other case. We'll see the spinal cord. DSA. Next. Yeah, stop. Back. Yeah, good. Anyone? Please get up, discuss this, make mistakes. We will discuss. That is the best way to learn. Anyone who wants to discuss this? Young lady, she was around 35 years old, and she had been having progressive, almost like a quadriparesis-like situation for the last 2 to 3 years, and she was sent to us for embolization. What do we see here? And we can apply quite a lot of the principles that we have discussed just now. So basically, okay, I'll start off the discussion. You see a vascular network in the region of the spinal cord. Yeah, sure, please run it. Play it, Cine. And let it play, let it loop 3, 4, 5 times at least. Yeah, anyone? Okay, let us try and see the super selective runs and then come back to this so that it makes more sense. Next. Next. Yeah, this is the lateral view. Let it play a couple of times. Okay, next. Next. Okay. नहीं, इसका सुपर सिलेक्टिव रन्स था, कल देखे थे. स्टॉप, इसी को रोको, बैक जाओ, बैक जाओ. या बस. Yeah, anyone? Okay. Vertebral artery, as we have discussed, the vertebral artery is basically a homologue of the radiculomedullary system. So since this artery, this lesion is higher up in the CV junction, this is getting supplied from the vertebral artery. From the vertebral artery, you see one prominent branch here and one prominent branch here. So just now we were discussing about the lateral spinal artery. So this is the pica. The pica is also supplying the AVM. So when the pica is supplying the AVM, it has to be from the posterior spinal system. And this, what is this? This is the anterior spinal artery. This is a hugely dilated anterior spinal artery, and this anterior spinal artery is also going into the AVM. So now you have a situation in which you have supply both from the anterior as well as from the posterior. So this AVM is got a supply. This is an intradural intramedullary lesion with trans-cord supply from the posterior part, from the posterior surface, from the lateral spinal artery, and from the anterior surface, from the anterior spinal artery. So how do we approach this? What do we do for this? Anyone? Super selective? First we went into the lateral spinal artery. We saw from the lateral spinal artery, and then we came into the anterior spinal artery. So whatever principles we discussed for the anterior spinal artery will be the ones that will be applied in this case over here. Super selective लेके नहीं आया आप, छोड़ दिए. इसका embolization नहीं लाया आपने? होगा ना? हाँ है तो. This is an old case. Next. Super selective. Next. Yeah. No. Go back. Go back. Stop. Anterior aspect of the cord. Lesion is predominantly posteriorly placed, but as you come lower and lower, this comes across the cord, through the cord, and this part, the lowermost part, is through the anterior spinal artery. So here we have a situation in which the antero-inferior part of the AVM is predominantly supplied by the anterior spinal artery, and we have a posterior-superior part of the AVM which is mainly supplied by the lateral spinal artery, or you can call it the pica, because the entire lateral spinal artery is engorged and is engaged in this. Next. Coming from below. Yeah, go back, go back. Stop. That is a tiny supply from below, and this is again supplying the lower part of the vascular malformation. Next. Microcatheter. Next. 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 अभी जाते जाइए. हाँ, this is navigation. Next. That's a microcatheter. Yeah, this is the microcatheter. You can see this is pointing medially, so this is the anterior spinal artery. When we are trying an injection from the beginning, the sump effect is so much that everything is getting washed off. Next. Next. We go deeper inside the anterior spinal system. No, this is in the lateral spinal artery. This is the pica part, the lateral spinal part. So now this is the dorsal part of the AV malformation, the posterior superior part, predominantly plexiform, predominantly extramedullary, and getting opacified. The entire arteria vasocorona is involved. We will come to this a bit later because this is easy to embolize. So we always finish off the difficult parts first. So go to the next one. Next. Oh no, that has been embolized. That's gone anyway. Next. 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 Yeah. Now, probably we are trying to go into the anterior spinal system. Next. 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 Yeah. Now we are in the anterior spinal artery. Next. Yeah, stop. So now we are in the anterior spinal artery, that is the midline, and what you are seeing here is the microcatheter has left the midline. So the moment you are in the midline, the moment your microcatheter reaches the midline, somewhere here, what you have to do is you have to enter into the anterior spinal artery and then go across the midline. So the moment you go into this segment, the moment you go into this vessel, you know that you have left the anterior spinal axis, and if you were to embolize in that area, and if you have a risk, it is a risk of a Brown's cord. It is not a complete section of the cord. So now please let us show the video. Yeah. So midline, the microcatheter is in the anterior spinal artery. You can see this curve here, the slide, but again the spinal cord is just as big as this. So the bend that you're going to see is going to be a very tiny angulation, which tells you that the catheter is out into the sulcocommissural, away from the anterior spinal. You have to master the flow here. You have to make sure that you have no reflux, because the margin of reflux is half a mm. You will be in the anterior spinal system, and that's it. It will be permanent quadriplegia. Next. So now we go still deeper into the nidus of the AVM. We go slight couple of millimeters more inside, and then we try and check the flow. We do different pressure injections with different concentrations of dye, and we look at the opacification. We see how exactly the entire thing is opacifying. So basically, even though you were seeing a huge vascular malformation, 90% of those vascular malformations were veins, and maybe 10 to 15% was the so-called arterial nidus. So the target is only this much. Also remember, in the spinal cord, there is no place for complete embolization. In the spinal cord, even if you reduce the flow by 50% to 60% in the first sitting, the patient is going to do well. And then you can bring back the patient with the change in hemodynamics. What happens is, the moment you embolize this compartment and the AVM is still there, the other vessels start becoming more prominent. So when you bring that patient back after 2 months, it is much more easier for you to tackle the situation. In the spinal cord, since the margin for error is very less, we prefer the hemodynamics to adjust and then do the second session. So next. Now exactly inside the sulcocommissural, distal sulcocommissural, good position. Next. We wait, we check, we see again, we give some nimodipine. Sometimes what happens is, because of your catheterization, some of the vessels go into spasm. Now you can see a much larger part of the nidus opacifying from the same area, because we are wedged in and we have dilated. Next. We are still trying to reposition it a bit more. The target for this time is going to be this compartment, because the lower compartment is the one which is also getting supplied from the anterior spinal and the posterior spinal. This artery is posterior. This artery is anterior. It has been confirmed on the lateral view. This is what you were asking. Sometimes you get a vessel with a hairpin bend. So this is one of the arteria vasocorona posterior connections which has been chosen. And now, when we have gone, see the microcatheter was here, we have gone almost up to this area. Next, when we do the injection, you will see during the injection, even this vessel will fill retrogradely. So now we know that we have mastered the flow from both the compartments, from the anterior as well as from the posterior. So the moment you inject into this compartment an embolic agent glue, these two supplies will go off at the same time. Next. Now we inject. We inject the entire nidus of the AVM, and we see that the glue the contrast. Next. I think there was a view in which the contrast was going into the, yeah, you can see that? Now that is also filling through the anterior compartment. So anterior spinal artery, AVM nidus, posterior spinal artery from behind, the entire axis is now achievable with one injection. This is not ASA. This is not ASA. This is PSA. This is PSA. Yeah, you are seeing this up and down, but remember this, when we show you the lateral view, you will find that the glue in this will be on the posterior side. Next. 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 Oh, अच्छा, नहीं, go back. Glue हो गया. Back, back. Yeah, this is probably the glue injection. Yeah, that is the glue injection. You can see that there is absolutely no reflux, and you can see that it is starting to come and fill the posterior part of the nidus as well. Next. Next. That is the glue cast. Next. Next. This entire portion of the AVM, which was the transmedullary component, has been knocked off. Now you have multiple small feeders coming in from the posterior circulation, from the posterior arterial vasa corona, which is still maintaining this venous system. Over the next 4 to 6 weeks, this entire venous system will collapse. You have to make sure that you anticoagulate the patient at this time, because if you don't do that, you will have a huge hematoma sitting in that area, and the patient will again end up with a venous infarct or with mass effect because of the expanding hematoma. Next. In the first session, we stopped at this. Now, yeah, next.
How long did you give anticoagulation?
1 week. Yeah, stop. Stop this. Yeah. See, now what is basically left is, remove the subtraction, please. Yeah. You can see that is the spinal canal. That is the posterior part. So you can see this glue is on the posterior part. So this entire thing is a spinal canal. That is on the posterior part. There is glue in all this area. Now put the subtraction back. Yeah. And you can see that the lower part of the AVM is completely gone. These are fine areas again, which are again posterior and lateral. So therefore, this was posterior and this is lateral. So the lateral spinal contribution to this AVM was still left behind at this stage, which we subsequently did in a second sitting, which is very simple, because now that you have taken off the entire anterior spinal component, whatever is left is the posterior spinal. So that is an easy job to do. So this was one of the illustrative cases. We'll show much more. We'll show much more, because since we discussed the lateral spinal, I just thought I'll show this. Fine. So any questions on this case? See, now that is the tip. Go back. ये तो अभी तो बहुत अंदर चला गया है. Go back. Or back. Next. Yeah. You have to use the wire. You have to use the wire. Otherwise, what will happen is, it will keep on getting stuck into tiny branches which are coming off from the sulcocommissural. Because please remember, the sulcocommissural is not a single artery. The sulcocommissural has multiple tiny branches. And maybe the multiple tiny branches are going to normal brain matter. So if you don't use a wire, your catheter is a 1.2, it's a very small microcatheter, it will keep on getting stuck into small branches. So either use a 1.5 microcatheter or use a 1.2 with a wire, so that your wire actually shows you the way, stiffens the distal end of the microcatheter, and then you push it in. See, in the beginning, we were using the wire. In fact, we use the wire, but once it is in the main channel, then you just keep on pushing it. You just give it some slack, it will go in.
Keep the wire as a little
like a mandrel inside the artery, so that the tip is stiff, but the wire is not poking out. Because these are 007 wires, this is a Mirage, so the chances of perforation are very high. So you just keep it at the tip, maybe extend it 0.5 millimeter, torque it a couple of times, so that if it is stuck into one side branch, it just gets released and then you push it in. Okay, anything else? Any other questions? No other questions? Okay.